Good evening. We're going to go ahead and get started. I've just a few notes to help us orient. Tonight's significant conversation is what's age got to do with it, expectations and communications across generations. It sounds like a simple topic. It's one that I think we all struggle with, and we learn more about it constantly. We've had a number of such discussions. We haven't had this one. And what do we mean? Well, we want to talk about the linkages and differences of approaches and views on life and the way we learn and communicate between the silent generation, which is born between 1925 and 1945, the baby boomers right after the war, 46 to 64. Generation X, 65 to 80. Then the millennials taking us up through 95. And then the Z generation through 1996 through 2012. And now we have the Alpha generation, who I guess started in 2012. So they're 12 to 14 years old, or up to 12 to 14 years old. So it's a pretty dynamic range, and as every generation does, there's differences in approaches, life experiences, but I think it's fair to say that the challenges of communication are probably greater now than they ever have been, and we're all witnessing it constantly. I would add in the blip of COVID, because what we're seeing in the age 5 to 25-year-olds is blips of activity as they move through their education programs, which are different for every one of those sub-age groups. It just so happens that yesterday, the President's Cabinet, which they allow me in on, brought in a coach from John Carroll, who's been a football coach for the last 30 years at 6 different institutions, including professional athletes, etc. And he commented about how his world is so completely different now that if he's doing a speech before a game, it's got to be 45 seconds and have 6 points, and he's got to go up to each player and give them a hug. That there's a relationship link that has to be quite local and intense, that their attention span's incredibly short. If he's going to give out a play, he's got to figure out how to do it in 12 seconds or else they're not going to listen. That their artificial interactions are all over the place, and they're all social mediaized. So that was a reflection on perhaps our undergraduate and graduate students, but here in medicine we've got folks who are just a little bit older, if you would, and help us through a variety of activities. And what we try to do in these significant conversations is take on something that we don't exactly understand, so we want to use a communication strategy to help us figure it out. I'm going to introduce Cynthia Caboo, but let me start with our panel of really informed individuals who think and worry about these things a lot. So Ted Perrin, who I'm told is a baby boomer, is the Isabel and Carter Wang Professor and Chair of Medical Education at the School of Medicine, graduate of the school, internal medical residency at Cleveland Clinic, and is well known for his work on substance abuse and prevention and education, and is a great educator. Next is Ken Remy, who joined us recently, Generation X, I'm told, director of the Blood, Heart, Lung, and Immunology Research Center at Case and UH, and director of Pulmonary and Critical Care Medicine, a physician scientist, and he'll be talking about how one gains resources and independence in these complex times. Sarah Augustine, also Generation X, is chair of the School of Medicine Committee on Medical Education, so she gets to deal across generations and one group evaluating the other, and has had a very strong role at the Cleveland VA, where she's been Director of Clinical Performance and has a tight understanding of both education and administration. And then moving into the slightly younger crowd, Dr. Tenley Anderson, who is millennial, is a resident in child neurology at University Hospitals, did her medical degree at Wright State Boshoff School of Medicine, and then came here for residency training, and probably understands better than most of us in the room how you can learn starting with digital approaches and managing work-life balance, which I'm sure the baby boomers amongst us never understood. And then a college undergraduate senior, Shahida Uehad, who is double majoring in neuroscience and psychology. And thank you for joining us, and don't be intimidated, I'm sure you won't, is our Generation Z representative. No challenges for that. So I want to thank Cynthia and Mark Lucio for organizing this, getting us together, getting out the advertisements and the approaches to it. I hope we have a really good conversation. We'll have short presentations after Cynthia introduces the real topic, and then we'll have, I hope, a thoughtful discussion, and hopefully everyone in the room will have something to say. Cynthia.
I'm keeping an eye on the time. So Dean Gerson has already introduced me. I know many of you. It's good to see some familiar faces again in 3D and not just on a tiny little screen. I have the privilege of serving as the Vice Dean for Faculty for our School of Medicine. The theme for this evening's event came directly from you. Out of conversations we heard from faculty, from staff, and trainees about some of the challenges in terms of communicating between and across and within these generations. And I think that illustrates that we try to be very responsive to the information that you give us and to design events to help address that. We are fortunate to have 5 different generations in the workplace now. Dean Gerson went through them, but I think it's important to realize that these different generations are defined primarily by shared experiences and not age. And not all members of a generation fit neatly into the same box. So effective organizations need to understand the impact of those shared experiences on each generation's journey, while challenging stereotypes about generational preferences. I want to emphasize that important tension one more time. Okay? It's an interesting tension between acknowledging the impact of shared experiences while not making false global assumptions about individuals based on age. Jesse Stanchek identified some of the most common generational challenges in a piece in Enterprise Solutions, and I'm just going to share some of those in the workplace. For example, it might appear that generations differ in terms of values, but that's misleading because core values remain the same, but how you act on those values may differ. For example, Gen Z, and we know that Shijuchi is very much involved in climate advocacy, is very concerned about sustainability. But some of us remember the 70s when the environmental movement was really rose, okay? And so those how we talk about it may differ a little bit, but the core shared values are the same. Others that Stanchik identified included communication styles, work-life balance, and the adoption of new technology. I'm a Luddite, and for those of you who don't know a Luddite, I am analog. I'm not digital, and that's stealing from Elizabeth's line, okay? So what we need to do then is, if we're wise, we can leverage the advantages of having so many different generations with different perspectives and ways of knowing and doing in our School of Medicine to build better community in which everybody flourishes while we advance our core mission. So for today, what I'm going to do is we're going to try something different for those of you who have participated in these significant conversations before. Briefly, we're going to present 2 scenarios tonight. After each scenario, we're going to ask you to pair it with somebody next to you and share if you think you've ever been in a similar situation, identify some of the challenges in the scenario, and share your thoughts with each other. After that, will quiet the room down, or I'll try to, and we're going to have our panelists provide their insights in terms of these scenarios as well. Then I want to emphasize, too, that the panelists were asked to share the scenarios with friends and colleagues in their generational cohort to get several perspectives. So the views they're presenting are not necessarily their individual perspective, but those that they've kind of gleaned by talking with their colleagues and friends. We will then poll you to solicit more feedback and identify best practices for moving forward. We have a tight agenda, so I'm going to apologize up front in that we may not have as much freewheeling discussion here in the auditorium, but there's lots of room for that in the reception that will follow. Okay? Before I introduce our panelists, I want to acknowledge the Significant Conversation Working Group, who have been very valuable in terms of contributing their time and expertise and ideas to help make this evening's event a success. And so moving forward, these are those members: Mark Alicio, Aaron Lamb. Why don't you raise your hands? Aaron, raise your hand. Thank you. I don't get to tell Aaron what to do very often. Barb Daly, I don't see her in the audience. She must be on attending virtually. Rhonda Murad. Yep. Rakshanda Raman, who I know couldn't attend, and Jim Young. And what I want to emphasize is, once again, these individuals, and Mitch Drum. I forgot Mitch. I'm so sorry, Mitch. I knew I forgot somebody, but he's essential. And these individuals represent all of the sites within the School of Medicine, because we are all one School of Medicine. Okay, I'm going to ask the panelists to come up now, and I'm going to just do a little bit of a correction, because there was a little bit of an error and somehow in the information that was shared with the dean. So Ted, if you can come up and have a seat. I think it's important to emphasize that Ted is a Cleveland Heights born and raised, and an alum of our medical school. And he's been honored multiple times for his teaching in the medical school, with particular interest in communication and professionalism. I want to have Dr. Trenley Anderson come up now. They are resident in child neurology at University Hospitals, and their professional interests include neuroplasticity, epilepsy, movement disorders, functional neurological disorders, music therapy, health humanities, and medical education. They are Virginia native, and this is the fun part, enjoyed a brief career as a classical clarinetist before pursuing medical education here at Case Western Reserve University School of Medicine. Sarah? Dr. Augustine has already been introduced by Dean Gerson, and I think I just want to emphasize the incredible work that she does in terms of her service to the VA, and really her commitment to training in graduate medical education as well as medical school. And Shajuchi Wahed, as Dean Gerson indicated, she's studying some of my favorite things in the world, like neuroscience and psychology and ethics, and is involved in research at the Cleveland Clinic Epilepsy Center, as well as the CWRU Clinical Neuroscience Lab. And then Dr. Remy. And as Dean Gerson indicated, he has held multiple leadership roles. And his role really here is that of a clinician scientist, because he has a basic science lab as well as working in that clinic. So we can have a robust discussion. Thank you. Good. And I'm just keeping an eye on our time. So what we're going to do is move right into the scenarios. And I'm going to read this so that people are aware and we've got everybody on the same page. And this is a shout out to Rhonda Murad, because she's the one that really did the heavy lifting with these scenarios. Dr. M, a family physician, has agreed to mentor a first-year medical student, JC, who is interested in sports medicine. They agreed that JC will accompany Dr. M in the clinic twice a month, as well as collaborate on an abstract submission for a case report about a patient they saw together. Dr. M shared their personal cell phone number in case JC ever had to call in sick unexpectedly. For routine communication, Dr. M responds to emails within 3 business days or less, and requests that all mentees do the same. So they've been working together on the case report via email for the past 6 weeks. JC has diligently produced 2 solid drafts to which Dr. M has responded with timely feedback. Dr. M gave JC feedback on the second draft with 2 weeks left before the deadline to make further revisions. JC, who was busy with exams, followed by Thanksgiving travel, waited until the day before the deadline to finalize the submission and text Dr. M with a few final clarifying questions while Dr. M is finishing up dinner and preparing for a full clinic day tomorrow. Okay? So I think all of us have been in these kinds of situations. There's a time crunch. You're trying to set boundaries. And what I want you to do is just think a little bit about, have you ever experienced a scenario like this? And there's Barb. I just see you right there, Barb. And have you ever experienced a scenario like this? And how do you move forward? And what are some of the issues or tension points in there in this scenario? So if you could turn to your neighbor, please, and I'll give you about 5 minutes to do that. And then we'll focus on our panel. Okay. All right. I'm going to ask you all to be quiet now. But I love the buzz because evidently this struck a chord with some folks, right? And so it means that we're identifying maybe one of those potential challenges. And I'm going to see if I can get the panelists to be quiet because they're going to have a chance in a minute here. Okay? Excellent. Thank you, guys. So what I want to do then is just open it up to the panelists in terms of what are some of the issues that, you think of in this kind of setting, and how do you address that? So Ken, as somebody who is in the clinic and running a lab and trying to do all this work, why don't you share some of the things that you've heard from your colleagues and so on?
Okay, perfect. Well, I am Gen Z. I just want to make sure everyone knows that up front. And I will tell you the first thing just before we get to that is when the dean put up what's age got to do with it, I know I'm Gen Z because I immediately reacted with, what's age got to do with it? So you're Gen Z because where that comes from. And the second thing I would just say is I have notebooks, and my notebooks all look like VHS films. So that's how you know your film strips and VHS. Anyway, back to your question, sorry.
Yeah.
So I've asked this question to a couple people, and we just had a really great dialogue about this. So I think there's a couple different aspects of this that actually earlier in my career and where I am now too, and others I've talked to have also transformed sort of their thinking on this. First of all, the senior person in this relationship got 2 drafts, which is fantastic first and foremost, because a lot of times you get no drafts the night before. And so on one hand, you have a motivated trainee or junior folk, and they clearly are busy. One of the things I think that doesn't happen a lot and needs to happen more is that the senior folks, I think a lot like myself, we assume that people know that we're busy, but they don't know to the limits and to the extent that we are busy, and we probably don't do a good enough job when things are due to help guide folks to say, hey, listen, 2 weeks ago we did this. I know you're busy. Let's have a couple touch points by Zoom, 5 minutes just to check in. Or here is an Excel spreadsheet where please follow this. We can try to get there. Or I have clinic the day this is due. When do you realistically think you can get this? Because I remember when I was a trainee and when I became a faculty member, we're having trainees, that I used to say a lot, poor planning on your part is not an emergency on my part. But then that wasn't right, because over time I started to move away from that, because even if I got it the night before, it was not, I would say, you can't do this again, we can't submit it, but then I would acquiesce at 9 o'clock at nighttime and just start rewriting the whole thing so they could submit it, because I didn't want to get in the way of what would happen. And I think a lot of people are well-intentioned like that. But I think what's different is the generational difference is most, I think, Gen Z people are very, I actually wrote down, we are adaptable, we like our work-life balance, we like flexibility and autonomy, and we put our heads down. Because a lot of us are coming from baby boomers who came out of the war, who put their heads down and got their hands dirty and worked hard. And so we have that mentality, but we also kind of understand the other side, which is that we understand that the world is different and that people use digital technology a lot more. And so trying to embrace that in a fashion that makes sure that better communication occurs is something probably we could do better.
Excellent, excellent. So Judy, I think you may have been in positions like this, right? Where, you're looking at getting an abstract in, you're juggling all these things because in addition to a double major, she's got a lot of minors as well. And so what are some of the things that you heard from your peers?
Yeah, I think a big thing that's happening behind the scenes, I guess, in this scenario is the different understandings of the level of commitment for the student and what their role is in this project. I have some of my peers are in the lab all the time, like at least 10 hours a week. Other peers of mine are like in the lab much less. Some are remote, some are in the lab all the time. And so that's like a difference that can naturally occur and is acceptable by a PI, but it's really communicated and understood with your PI. However, here with their exams that were happening in Thanksgiving break, the student wasn't expecting to work during that time, but maybe the PI was expecting them to. And so that difference is ultimately resulted in the abstract or the draft being submitted to the PI a little more last minute, and I feel like a better communication of what the student's role and involvement in the lab would have fixed this a lot earlier. I also think that better check-ins with a PI could have definitely prevented this from happening. I'm blessed and fortunate to be able to meet with my mentor at least once a week, even though she's a very busy person. And while that might not be true for all students in labs, like some form of communicating and checking in and being aware of the deadlines before they happen would have prevented this misunderstanding between the PI and the student of when to turn things in.
Go ahead. This is up to you. I'll keep an eye on all of you.
Can I ask the question to the baby boomers in the room? Am I allowed to, or no?
Are you sure?
Okay. So I'm just curious about, so we are inundated obviously with technology, which is fantastic because it controls so many great things. On the other hand, we're inundated because you can lose hours of your time on the technology that's in your hand, or it can ping you all throughout the evening, all throughout the day. And so I start to think about the baby boomers, for instance, if you don't mind, who lived on Kodachromes and had overhead projectors and used word processors for everything and used Redline for everything. But they didn't have all of those, to some ways, distractions. And so there was always assumptions that people putting their heads down and getting things done, and vice versa, that was what is expected of their younger generation as well, because, you know, as people were on Prodigy waiting for 6 hours for their internet email single one to load, you were doing work. You weren't streaming your phone or anything like that. I'm curious to see this question, how one might have looked at it 30 years ago.
Ted, do you want? I can add in too because I'm barely a boomer.
So I'm a very young boomer, until I was told by my 5-year-old granddaughter on WhatsApp from Texas that, no, actually, Granddad, your hair's white. I was trying to pass it off as gray. Deadlines were very different when I began to learn this craft. You had to mail things in. You had to get them typed out. If you were doing a presentation, you needed to make your slides and then get the slides actually made, and et cetera, et cetera. So there was a lot less emphasis on the last minute, or the last minute was many, many, many minutes earlier, just because things couldn't go so quickly. So it's been quite an adjustment.
Since you have the mic, Ted, why don't you go through and just, in terms of the initial scenario we talked about, because you've got these imminent deadlines, you've got these different forms of communication, people are trying to figure out different ways of like balancing work-life and other responsibilities, and I'm curious of your thoughts on that.
Yeah, so as I spoke with peers, and my own thoughts about this, clear communication up front. It looks like it started off well, but the intermediate, the periodic check-ins and the intermediate communication is really important, and especially after each nodal point. So after each time that an abstract or you've reached a certain kind of intersection, if you will, to use a driving analogy, a different intersection in the project, it's so important to check in because the road ahead can look very different to a student who's whose life begins after dinner in terms of working, as opposed to an attending whose life ends just before dinner, and don't talk to me till tomorrow morning, kind of thing. So I think first a misunderstanding of each other's normal schedules and what the pressures of those were, and a lack of signposting. I think are the themes that I heard from my peers and cropped up for me as I read through.
Do you think there's a fear of submitting something to the mentor that's not perfect? There's a fear of not meeting that threshold of perfection, and yet many of us are not expecting perfection, but yet because there's not that explicit conversation saying, it's okay if you don't give me perfection, I will put some time to edit this and teach you how to do that, perhaps drive some of that problem.
Maybe Trenley and Judy can kind of respond to that a little bit.
Sure. I think a desire for perfection and fear of not meeting expectations could contribute to procrastination. Additionally, some of my peers mentioned to me that in scenarios like this, they may simply be overwhelmed by the many things, the many responsibilities that they have, and may simply run out of time. And they thought that in some cases they would hope that they would receive some grace for being in the learning process of how to budget their time, how to behave professionally.
I would agree completely, especially with the procrastination. I feel like with deadlines, it definitely happens when you want something to be perfect, especially if that expectation is put on you or you felt that in the past. And also with all of life's chaos, majors, minors, and everything that you have going on, it may be difficult to get to things in time.
Excellent. Sarah, can you share some of your perspective, please?
I think also part of the challenge of this is there really is no downtime anymore. Even, for those of us who keep a calendar at work and it looks like your half-hour slot or your hour slot is free, it's quickly subsumed by direct messaging, by texting, by something that's pulling you in a different direction. So I think it can also, I was telling the group up here, I think if I personally had been given this scenario 15 years ago, I probably would have answered it quite a bit differently than I would answer it today. I like to think some of that's having more experience with other generations. I have 3 kids who are all Gen Z, and I work with a lot of medical students and residents, and have really come to understand that I really need to step back and think of what's going on in their work life scenario and what their other commitments are. I think one thing that Gen Xers in general struggle with sometimes is giving what we consider overly explicit instructions. And to us, it seems overly explicit. To another generation, I think well, I said, I'll say round start at 8, and a student comes in at 9, well, I didn't have patience, so, I assumed I didn't have to be there on rounds. And so there's nothing nefarious about that, but there is a gap in our instruction giving. One of the things I think that as members of different generations, whatever they may be, we need to understand how the person on the other end of the conversation perceives instructions. And is this somebody who's going to do better if we give very clear, explicit instructions? Or is it somebody who's of similar-minded, similar generation that we know we can talk a different language? So I actually, I think many of us have adapted or have tried to adapt our communication style for that very reason.
I think that's an excellent point. I think, too, the point that Ken raised in terms of how our attention is being hijacked and this increased sense of pressure. And I'm wondering if people would be willing to comment just a little bit that as the PI, I'm feeling under the gun, I'm being pressured, and I may be the one that's procrastinating. And what's my responsibility to this trainee who's really doing their best? I mean, 2 drafts, right? That's really impressive. And so I think there's that little bit of grace both ways, and how much of it is a problem that I have to own because of these attention grabs. So I'm curious as to what others think, because, and then also follow up on Sarah's excellent point about like how much is too explicit versus how much are we assuming they know what we're talking about. And that's really problematic because you don't want to appear like you're micromanaging, but on the other hand, you want them to learn, but you don't want to set them up to fail. So how do we balance all of that? So I'm curious as to thoughts on that and feedback from the trainees after the faculty speak.
Well, I think all generations actually procrastinate and are struggling with this attention grab. I struggle with it. I see my colleagues struggling with it. That again, there is your head is like constantly on a swivel, and it may not, procrastination may not be the correct term. It's sometimes an overcommitment that you don't even realize you're overcommitted when you're trying to help out with something that balloons into a bigger project. And as Ted mentioned, these timelines now are just like this. It's not, you know, I was of a generation that you had to print your Kodachrome slides to give your talk. And so you had your talk done a week in advance. Now you can submit literally, 5 minutes before it's due, and it's uploaded and it looks really nice. And I've taken advantage of that, but that's increased my level of stress for sure. And it makes very little time when one of these unforeseen scenarios comes in to the student who's trying to do their best, struggling with the same thing that I'm struggling with, and is hoping that I'm having a better day maybe than they're having. But I do think it's critical that there's grace on both ends of that. And in terms of just a comment on explicit instructions as pertains to this scenario, only use my cell phone for an emergency. Well, I'm sure the student thought, oh my God, I missed my deadline and I just submitted it late. That's an emergency. And I think if you don't clearly outline that for a student or a trainee, well, that's on you. I'm very explicit now. This is what you may use my cell phone for. If you need me immediately, this is the form of communication. If you need an answer in 3 days, this is the best way to get me. If you need an answer in 2 hours, this is the best way to get me. But I think the onus, it was really on the senior to if they don't want to be texted on their cell phone, then you have to kind of clearly outline what you feel an emergency is to your trainee, I think.
Excellent. Ted, I see you nodding your head.
Yeah, the old adage that if you want to get something done, ask somebody who's too busy is actually really true, and it's really true in all of our work, and it really does stress that work-life balance. And it's as true for attendings as it is for trainees. Trainees are, trying to find their way as they move along and buff and polish their credentials and learn as much as they possibly can. But often the mentors are people who aren't very good at saying no either. And as a consequence, I certainly have found myself mentoring people when I either didn't have the time or the energy or both to really do a good job. And that cheapens the opportunity for the student. And so I think it really certainly goes both ways.
I'm smirking because last evening, so I'm working on something for my children with some veterans out in West Cleveland. And I'm smirking because I left a message for a gentleman who was a WW2 veteran, which they're hard to find. And I left a message, and it was about 8 o'clock or so, and I was like, I'll just call him the next day. And at like 8:55, he called me. And I grew up with landlines where you didn't call someone after 8 o'clock because it was disrespectful. And then this gentleman who's a World War II gentleman is calling me almost at 9 o'clock. And I do find it a little bit humorous that because it's a little bit disingenuous to say don't text me or use my phone when that same person is probably using it to go on TripAdvisor or Uber Eats or something else continuously throughout the day. I think the point, though, about technology and setting potential limits, I think, is an opportunity for people, if they do set those limits, to say, I set these limits because if you text me, I might have my phone not near me. When I go home after a certain time, I may not have it near me, but feel free if there is something that's of consequence that needs to be discussed that night. By all means, I'm always available to be able to help under those circumstances. I think that's important. I think on the same respect, if you set limits to say, don't really text me or don't call me or don't email me after 5 o'clock, it's a little bit challenging to the person who is also seeing patients from 8 to 5 in the clinic, who's the trainee, who's writing notes, doing all these other things. And it really closes the door to say, I'm not really available for you. And it may send the wrong message. So I was telling our group here, one of the things, because I get a lot of meetings on Zoom, I started like walking at the hospital 11 to 11:30 every day. It's blocked off on my calendar. No one can put a meeting there. But I was doing it because a lot of folks wanted to meet with me, trainees and stuff, but they walk with me. So they just say, if you want to talk with me, you meet me at Bowell at 11 o'clock, we walk for a half hour. But I didn't realize until I started getting feedback, this is great. You know, people are like, Dr. Remy, this is great. You're accessible for us when we have last minute questions. We always know you're available. And you know, it's hard to realize that because your calendar is usually booked out solid. But the message when it's booked out solid is don't disturb me. It's the George Costanza kind of, I'm busy and I must be, you know, I'm angry. And that's not true. You are trying to find your way to become more accessible because you do care and you do want to help. And so I think that some of these discussions I think are helpful to communicate to the trainees and vice versa so people understand what their lifestyle might look like.
Excellent. Shajuchi or Trinley, which of you wants to comment first? Okay.
I really like this idea of explicit instructions, especially as a trainee, just because I feel like we don't have this understanding of the norms. This is often our first time writing manuscripts or going to conferences or doing these big things, and it's important for us to hear what the expectations are explicitly from people who have been in the field and know what they want from us. In terms of availability, I've been very grateful once again that my mentor is always available and is always working, which we'll talk about later with the work-life balance. But I've been very grateful in terms of my own schedule because as students, we are doing things very late at night, especially after our classes are over. Recently, we've been having classes until like 6 or 7 sometimes, like as an undergraduate. So often our research time ends up coming up after that. So it's really important to have mentors that are available and tell us when they're available for us.
My input is quite similar to yours. Addressing the question of whether instruction should be detailed and micromanaged versus leaving room for assumptions and flexibility. I think my peers would say that expectations should be outlined in detail and not assumed. If there should be or could be room for flexibility, maybe that can be in how those expectations are met.
Okay, excellent, excellent. Any final tidbits from the panel?
Yeah, I would just say too, I think some of the disconnect for the Gen Xers, you know, we literally grew up in a training environment of see one, do one, teach one, which essentially was code for good luck, you're on your own, call me if there's a disaster. And that is literally how we trained, and I don't think that is the correct way to train, and I think many of us hopefully have moved away from that. But there is still a piece of that ingrained, like, just figure it out. Just figure it out. And that's not how the current younger generations operate. And I think we need to. Respect that. And if we don't, we should anticipate the result that we're going to get.
Good point.
I totally agree. on the other flip of the coin too, though, is I think that there is sometimes a struggle with also don't reach out or contact me before you've taken a moment to think about it yourself. Because sometimes you get folks that just keep contacting you, but you can tell that perhaps there's not a moment where they're actually assessing the situation, thinking through it critically on their own. Mm-hmm. And that gets a bit frustrating too. And so I think it's sort of balancing between being open and accessible, but also having some expectation that the person on the other end is also putting in some time and effort, obviously, to want to be part of that relationship to gain what the end goal might look like.
Excellent, excellent. I think what we're going to do now is we're going to switch then, and we're going to try and get some feedback from the audience. We're piloting here a poll everywhere, and so you can pull out your cell phones. And I want you to, sorry, I just realized. Anyhow, but what important aspects of this intergenerational expectations and communications in this scenario have we missed? What have we missed in our dialogue thus far? And so just go out there. This is how you can respond. You got a QR code. You can join via the web at that URL. And so you can just kind of go through and just plug it in terms of what are some of the things that we missed. Okay, good. Work-life balance has changed. Directions, explicit instructions, set expectations ahead of time. Compassion and empathy, that's excellent. You don't know what another person's situation is. Set expectations. Is not an intergenerational issue. That's a nice one. Maybe this is just a flat-out communication issue, right? Acknowledging the counterparty approach and engaging those terms instead of just explaining the counterparty. Both sides think more about putting yourself in the other's shoes. Empathy again. Personality type. Okay, good. First, mentor first. Normally I would have trainees do this. So those explicit expectations. Gender differences, that's interesting. We didn't touch on that. Maybe we can in the discussion afterwards. Younger generations may also want space to figure it out. Yes, thank you. So I tell my trainees, kick me under the table or give me feedback, okay? Anxiety due to pressure or expectations. Probably inaccurate expectations, right? Are these generational labels really useful to categorize people? Cultural differences. Excellent. Is this really an emergency? When do I actually need to answer? Good. Good. Do you think here we go. Nobody is contractually bound to respond to a text. Would you rather miss an abstract submission? Being radically upset at this scenario seems unlikely. Differences in conflict resolution styles and approaches. It should be seen as a learning experience by both parties, I think. Is it a generational issue or experienced versus inexperienced? Okay. Good. Are we about saturation, do you think, Michael? Okay, great. What we're going to do is we're going to do exactly the same thing, except we've got a different scenario now, okay? Scenario 2. A third-year medical student, TJ, is at the end of the internal medicine core clerkship. TJ and the supervising residents admitted a patient last night who presented with somnolence for 2 days in the setting of abnormal vital signs. After TJ finishes the oral presentation for this patient during team rounds with the supervising residents present, the attending physician, Dr. C, says, "Your history taking and physical exam were thorough. Your oral presentation was very well organized, making it easy for me to follow your thought process and understand your clinical reasoning. I agree with most things on your differential diagnosis, but there were a few diagnoses missing that should have been included, such as postictal state or subdural hematoma. The differential diagnosis for acute change in mental status is something all of you should know like the back of your hand because it's a common reason for hospital admission and the stakes are high for some of the do not miss diagnoses. Some of the causes are easily reversible, while others require emergent intervention with associated high morbidity or mortality. I suggest you read more about the neurologic causes of lethargy after rounds, because these are truly the high-stakes diagnoses that need to be intervened upon urgently. Also, I noticed the team continued this patient's benzodiazepine, which is very dangerous in a patient who's already experiencing somnolence and confusion. So we need to discontinue this medication right away and catch the nurse before the morning medications are administered. TJ feels a little ashamed and decides they will try to avoid working with Dr. C in the future. So this is really kind of giving feedback scenario. So once again, pair up with some folks, either the same ones or different ones, and discuss some of these issues and thoughts that come to your mind. How many of you have either given feedback or received feedback? What's the best way to do that? And are there better ways that we can handle this? And noting that this isn't an emergency situation, okay? But we see this also in lab presentations. So there you go. You got 5 minutes, and I'm timing you. I'm going to bring us all back in. Okay. Once again, thank you for getting engaged in this topic. I think this feedback is a real tricky issue, and that's one of the things that I hear an awful lot about in terms of challenges. So I don't know the answers, so I'm going to turn it to the experts on the panel here. And Sarah, since you're sitting right in the middle, I think I'll start with you, please.
I think this is a really challenging scenario, and I think many of us still struggle with how to approach this particular scenario, which comes up, all the time. We work with trainees, and if trainees knew everything before they started, they wouldn't be trainees, and they wouldn't have to go to medical school. So it's simply not realistic to think that scenarios like this are not going to come up. I also think that the attending in this scenario probably gave themselves a pat on the back, because I think they thought they were starting out with a sandwich. So, you did this really well, you did this really well, and then they just laid into them with like 10 other things that they didn't. But I think person's maybe doing well done on giving that feedback. So the piece of this scenario that really irked me was the fact that it was done in front of many other trainees and the residents. And I think there are ways that this scenario could be addressed that had the same outcome, and then some of the more explicit feedback be done one-on-one. So you know what? There were some critical things I'm worried may have been missed. We need to focus. Let's get the patient taken care of, and we're going to debrief about it afterwards. And then maybe pull that person out separately. I know for myself, even now, if somebody had done that in a group to me, it would not have made me feel really good about what I was doing. That was one issue. The other issue too, I'm going to call it generational, is I find oftentimes I have to say, I am giving you feedback now, because I'll have a trainee come up and be like, well, can we do feedback? And I'm like, oh my God, I just did a half hour of feedback with you. And I have learned that I actually need to label it. This is your feedback. I am giving you feedback on this case right now. So they understand, like, yes, this is truly a feedback session, even though we may not be sitting across the desk from one another. I'm giving you feedback on your care. And that's one area where I think a lot of us in our generation have tried to change our practice with that as well.
Excellent. Trenley.
Thank you. Oh, there's a lot to unpack here. My colleagues had a lot to say. I guess first of all, how could this have gone better? Kind of similar to what you said. They thought that right off the bat, once the attending identified that something urgent had to be done, that should have been calmly and quickly addressed. And then after the urgency had resolved, provide some feedback and teaching as a group, involving the entire group in the learning process. And then perhaps later talk with the student one-on-one with some more targeted feedback instead of doing it in front of the entire group. My peers all said the same thing. It's natural to feel uncomfortable when receiving and giving feedback, and it's crucial to have psychological safety in these environments. And so I looked up the definition of that, and I found that psychological safety is feeling safe to take interpersonal risks, to speak up, to disagree openly without fear of negative repercussions. And I'd add to that in educational settings, we can include feeling safe to try and learn without perfect execution and without complete knowledge, because the definition of a trainee is someone who's learning. I think normalizing the learning process and the growth process is essential to providing feedback.
Okay, brilliant. What about, you mentioned just a little bit about the role of the residents. Do you want to touch on that just a little bit? Because, yeah.
Yeah, one of the first things my peers also pointed out about this case is that the residents ideally should have practiced the presentation and advised the student in advance to set him or her up for success.
Yeah.
So that was another piece of the puzzle that was missing in this case.
And that may be one of the ugly parts sometimes of our culture, is there can be a lot of competition and hierarchy. Yeah, excellent. And opportunities for growth. Ted?
So I shared this scenario with several colleagues. Some colleagues said, boy, that's perfect teaching at the bedside. Another who has been a colleague of mine since we were interns together in 1982 and tends to be pretty terse, said, the student should plan to spend more time with the attending and less time with the residents who threw him or her under the bus. That was the entire feedback for that scenario. I think that one strong suggestion is preparing students as they leave the second year and head into clerkships, that teaching in the process of patient care can sometimes feel like it's overwhelming or dismissive because of the environment that it takes place in. Now, that isn't an excuse, but it's a preparation for students to try to be able to wrap their head around this kind of an event. I think another comment that I received very similar to what Sarah said is to look at the student and say, here's my feedback on your presentation. And then to look at the team and say, now as a team, let's talk about how we manage this kind of a patient and some of the gaps. Because identifying gaps in a third-year medical student's knowledge is very easy to do, and some people consider a varsity sport, but it really is inappropriate. And so students should be given feedback on their knowledge, on their thinking, and on the amount of knowledge that they demonstrated, and then when there's gaps in that, to try to broaden things to make it non-personal and more as a team-based learning environment. And there's one last, and that is that discomfort and embarrassment when gaps are exposed is honestly part of learning, but the goal of the team, including the attending, should be to try to minimize the embarrassment, not necessarily the discomfort, but minimize the embarrassment. And there really is no role for shame or humiliation in medical education.
Well said. Well said. How about, Judy, imagine that this is like a presentation in a lab meeting, or you're doing, our more formal meeting, or you're doing a presentation to a larger group, okay? And then you get this kind of feedback, because it translates to feedback in any setting. What are some of your thoughts on this scenario and from your generation's perspective, right, and what your colleagues have shared with you?
I totally understand from the student perspective the feeling of shame and embarrassment for messing up, especially like the feeling of needing to be perfect and then receiving this criticism in front of your peers and other people who you worry about how you're being perceived. And I can see how this might translate into like questioning how you are as a doctor and your role in medicine even. And I think the best way to cut it off from going into that deeper rumination is to really have empathy for the situation, I guess, and understand, particularly for this situation, the fact that it was such an emergency, like a life or death situation, and have empathy for the doctor who, while doing it in front of your peers might not have been the best move, is concerned for the life of someone, and just recognizing that might help you question your own role less and make it less personal for yourself.
That's a really insightful point, I think. Thank you. Ken?
So this is a really interesting scenario. I'm an intensivist, so I take care of children in the ICU and adults in the ICU, and so circumstances like this certainly there are life and death emergencies, and so it's a little bit challenging. I have a couple initial thoughts and conversations with other folks as well. First of all, I'm unclear why a third-year medical student, for instance, is in a situation where they're actually ultimately responsible for benzodiazepines in a patient and all those other things, which questions the level of supervision, which is a whole different conversation, perhaps. But it's interesting because when I first read this scenario, the last thing that resonated to me was the feeling of shame and not wanting to work with that doctor. And it's interesting because I remember certainly being, and I hate to use this term, dressed down by attendings and things throughout my training. But my reaction was not, I don't want to work with that person. It was probably quite the opposite. It was, quite frankly, wow, I really need to do these things. I need to go learn and do this. And obviously that's changed. And I agree with Sarah about the manner in which this was done is not appropriate in a group of folks. But it's interesting because that methodology for later generations perhaps can be paralyzing. It's kind of like, I'll give a throwback for the folks in the room, it's kind of like being in 2003 and PCOS goes down and you've got to actually write orders on the patient with ADC Van Dimmels from your Maxwells, right? That's what I knew how to adapt to. But if that happened in 2015 with Epic, folks that never had that experience would be paralyzed by that downtime, if you will, with EMR, right? Because they don't know how to react. And this sort of behavior towards them is challenging because it paralyzes them. And if it paralyzes them in a fashion that won't actually let them learn, that won't actually put them in an opportunity to do what's best and teach them how to take care of patients in these hard acute settings, then it's counterproductive, first and foremost. The other thing is I try with trainees, especially in residents and fellows, to ask them, how do you like to get your feedback? Do you want me to be direct? Because certainly in emergency settings where things are life or death, I have to be direct. There cannot be a lack of clarity of what needs to be done in patients that are dying in front of us. But I'll ask them that question. But here's where I struggle, is I'll ask, do you want direct feedback? Directed feedback, nothing mean or nefarious. And a lot of folks will say yes. But then you give it to them. And it's not received the way that you would ask them if they wanted that directed feedback. And that is something I struggle with right now is I don't know where to go. If you really want direct feedback and I give you at least it's like when you write a grant and you get the reviews back and you're so angry. And you're like, these people are wild and crazy. How could they write that? And then you get direct feedback from friends who give you, and you're like, I can't believe they didn't understand my grant. And then you say, well, it's probably because I should have done a better job actually of explaining my science, and now I'm going to make my science better. I struggle with this, and I don't know where that sort of middle ground is to be not direct and direct. Certainly the environment was inappropriate in my view for this case. But in the cases that are not this environment, one-on-one even, it can be challenging.
I think that's really the nub of what I think a lot of this scenario was focused on is how do we give feedback in a way that it's going to be received, where it's not viewed as punitive, it's viewed as a growth opportunity? I'll just share one thing that I want to hear tidbits from all of you in terms of what sits well with the trainees, with all of us, because we all get feedback, and what nuggets you have to share. What I tend to do is I make it behaviorally based, very much so. And I'll ask them to reflect. I'll say, tell me after that patient interview what was most effective about what you did, and why did you do it? And if you have a chance, what's the one thing you would do to take it up a notch? What would you change? So they're thinking asset-based first, and then moving in terms of like what you want to move forward. Because I'm struck by how much we all focus on what we don't know and our deficits rather than what we do, and you need to be able to clearly identify what's effective as well as what you need to work on. So that's what I try and do, and I'll just give a quick behavioral example. When you did this, what did the patient do, and did that help you get the information you needed or not? So I think that's just a tidbit, but I'm curious as to what everybody here thinks has been really highly effective in terms of giving and receiving feedback, because that's what we do day in, day out. And I view feedback, genuine feedback, as a gift.
There's one fundamental thing that if it doesn't exist in the scenario, then I think all is lost. I view this as when you give feedback, especially related to these sorts of areas, the person receiving the feedback has to know and understand and feel, I think, that we're talking about feedback because at the end of the day, we're trying to care for patients, and that the person giving the feedback cares about me caring for patients. And if that last part of it is not there and they don't sense that you care about them being able to take care of patients, I think then the feedback is going to be challenged.
Good. Why don't we just go straight down the road?
Yeah. I also agree about the need for it to be genuine, and like Trunley had mentioned earlier about how it needing to be like a learning experience, because that's what feedback should be at the end of the day. And having like concrete things to learn from could be like a great way to start, but maybe not offered. For example, I'm thinking about in this situation how like the person was told to do more reading on a certain thing. I feel like if it was told to me in that public sort of setting, I can't imagine myself later going on to read those papers and feeling good about myself still. However, if that was offered in like a one-on-one session as like direct, concrete ways of growing and learning from this experience, I would have had a much better time reading those papers later on.
I think Judy brought up a really good point too, that when something like this happens, we as attendings are very stressed. That we feel bad that something's going wrong for the patient. We're ultimately responsible for the patient. So I think sometimes we have this unacknowledged stress too, and that can cloud how we give our feedback. I think it's also really important to, when you give feedback, separate the behavior from the person. And I've taken to, again, explicitly saying, this is not a personal indictment on you. This is so we learn how to take care of this the next time, maybe more efficiently, and so the patient has a better outcome. I think, there's always discomfort when you receive feedback, no matter how well it's couched. I get uncomfortable when I get feedback, even when I think it's given very, very well. But I think it softens the blow if again, and I think in just restating what Ken said too, that we're doing this so you are a better doctor or a better student or a better resident at the end of the day, and so the person on the other end of that care is getting what they need and making that feedback more mission-based than anything.
Thank you. Trunley?
My peers basically articulated things that have already been said. The best feedback is actionable feedback. And to add something new, they said that the best feedback they got as residents so far gave tips for what they can do better, what specific actions they can do better, and then provided an opportunity for them to demonstrate that. So in this case, this medical student perhaps could be given an opportunity to continue following this case and perhaps look into adverse outcomes of whatever the issue was and further treatment. and to continue growing through the process instead of just receiving feedback and the situation being over.
Excellent. So to turn it into a better learning experience overall. Excellent. Ted, do you have anything to add?
I think the importance of making it a community learning experience as opposed to an individual feedback experience for the resident. Again, I was reminded by my colleague who interned with me many long years ago. We used to do morbidity and mortality rounds once a month. The noon conference would be some intern or resident would stand up in front of the department and present a case that they had messed up. And then the department would discuss it. And he reminded me that the year that I became the chief resident, we changed morbidity and mortality rounds. I hadn't even remembered this. So that the intern or resident who presented a case always presented a case that they had nothing to do with. And we only presented cases that were more than 6 months old so that most of the department had forgotten exactly who the individuals were that were involved. So it became less of an individual feedback issue, and it became more a departmental trying to learn and improve quality type issue.
Excellent. I think one thing I want to just throw out for the panelists, because we touched on it briefly on our little sub-conversation here, the smaller conversation, is what is our responsibility as a community if somebody's giving a grand rounds presentation or presenting their research findings, and you got somebody in that front row who's just pinging at them constantly. What is our responsibility as a community if we're committed to training students to be the best they can and promoting a psychologically safe environment to take charge, particularly those of us who may be more senior, because medicine is very hierarchical. And so I'm just throwing that out. I mean, we touched on this a little bit with Ted, so I'm going to start with you, Ken, and then Sarah.
Well, if it's the front row in this, it's the dean, so I'm just going to keep my mouth shut because I like my job. But I know I in those circumstances, certainly someone in the front row or figuratively in the front row pinging at someone and making unprofessional, inappropriate conversations, I think it's incumbent upon senior folks in the room to actually say, and you can do it actually in a way I think that disarms that person. And hopefully brings down the temperature in the room. Something as simple as just saying, if you know the person, listen, Sarah, I think these are great points. This is a really challenging case. I think everybody in here would definitely agree, and you're bringing up excellent points. However, I do think, X, Y, Z, I think that's important. I think the second thing, and Sarah touched upon it when we talked about it, is that we've got to give ourselves, certainly in training in these environments, grace. We don't give ourselves enough grace. And so I think making sure that the people that are presenting have that doesn't negate the fact that if things are done wrong or inappropriately, or there's time for feedback that's going to help the situation, that people don't give that feedback. But there's a way to do it, and do it in a way that affords someone to have some moniker of self-respect, but allow for integrity to be in the room.
Exactly. So self-monitoring the community, kind of. Okay, great. Sarah, do you want to say anything? I'm giving you guys a pass if you want.
I think we actually have a moral imperative to stop such behavior if we see it. And to Ken's point, I think there are ways to do that without standing up and saying cease and desist. Mm-hmm. I think there usually when somebody engages in that type of behavior, either they had a really bad day, or more likely than not, they're very insecure in their own role in the profession. And I think there are ways to bring that behavior down without embarrassing the person who is behaving that way. Maybe a side conversation afterwards that might be a little more targeted. But I think we have an obligation to do that if we're going to maintain psychological safety, is to prevent that from happening when we see it happening.
Okay, great. Ted, you want the final word?
Yeah, I think that intervening in order to maintain a safe environment for learners, all the while being able to be sure that they get feedback if and when they need feedback is critical. But feedback really is never going to be useful if the environment isn't safe.
Okay, excellent. So with that, we're going to poll all of you again in terms of what important aspects of intergenerational expectations and communications in this scenario have we missed? What did we miss? And so you're going to have a QR code in just a minute with the same URL, and please let us know what we missed. Okay, the opportunity to use guided questions, even in an emergency. Using language such as we and let us rather than I think and you should would convey the same education and feedback while emphasizing collaborative and team-based approach to care and avoiding defensiveness and humiliation. Excellent. The scenario concerns largely hierarchical, not generational differences. Hierarchy exists in the hospital often, but not always correlative with generational gaps. This is true. Chairs may be younger than department faculty, but still have to provide feedback. So once again, it may be not a generational issue, but a core communication issue. The real world, there's no such thing as a safe environment. We need to better prepare our students for this reality so they can handle the stress. That's a tension I've heard too. How do we prepare them for the training? How will folks learn how not to take things personally, break the cycle? The way it's been done isn't the way it has to continue. Excellent point. Differences in general understanding of accountability. Get to the point in feedback quickly and give consideration and respect first, then give feedback. The fact that it's an emergency and the feedback tone may be a learning moment never to be forgotten. Setting expectations of feedback and sticking to it. There is a difference between call out and call in. That's nice. We can elaborate on that maybe in the reception. I'm not sure many safe environments exist for learners at any level these days. Thus, there's little chance to learn how to receive feedback and who teaches people how to give feedback. We've got a last slide on that. Understanding the feedback as a learning tool. If the attending was using sandwich technique, they left it incomplete. Yep, open-faced sandwich needed to add positive reinforcement at the end, not just at the beginning. Very accurate. We want both pieces of bread, right? People need to be inquisitive. Curiosity is wonderful in terms of helping us do better in communicating with each other. And nobody on the rounding team discontinued benzo. If you are the attending physician, not only is your responsibility to the health of the patient, but also to the medical education of those who are rounding with you. Be irresponsible to have this conversation in a private setting. The entire group benefits. Dr. C never called TJ names or personally offended their character. Feeling ashamed for failing to miss critical medical knowledge is a normal feeling, irrespective of Dr. C and TJ's relationship. Okay. Great discussion, very insightful. It's important to remember that as one advances in their career, it doesn't automatically mean that they're effective mentors. Very, very true. Perhaps discussions like these can enhance the understanding of a good balance between feedback and a positive approach. Some more focus on the positive opportunities for intergenerational conversations and shared commitment would have been helpful this evening. Okay, we're going to get to that next. I think the student not wanting to work with an attending because of feedback is a loss from the student perspective. They are there to absorb everything and be better. Okay. This was less an intergenerational issue as much as a failure to communicate to a trainee in a way that both highlights critical knowledge gaps while encouraging learning in a supportive environment. Okay. Good. All right. What about understanding the various roles within the setting? How can we promote a safe environment when as a society we reward bullying and intimidation? That's definitely over a glass of wine, okay? All right. I think we may have hit saturation. Why don't we go to the next one then, please, Michael? So what we're asking for now is feedback, guys, okay? And it's pretty easy to find me. I'm the only Kaboo pretty much anywhere in the world, except I think South Africa. So, you know, in topics that you want, I can funnel them on to the working group. And what we wanted to do next is just have you respond in one word. This only works if you use one word, right, Dr. Lamb? One word. What is the single most important variable to ensure functional intergenerational workplaces in which everyone feels safe and thrives? What is the single most important variable to ensure functional intergenerational workplaces in which everyone feels safe and thrives? Sincerity, empathy, well, you can read these. Communication, respect, listening, check in. Look at this. Communication, transparency, listen first. Oh, somebody cheated. They were very clever, weren't they? Exactly. Can you see what's coming out really out there is communication and empathy. Listening. Excellent. Grace. Okay. All right. We'll keep these going, and I think this has been recorded, so it's available for people who are unable to make it to see what this conversation yielded and where we think we need to go next. Okay. With that, I want to thank everybody who attended, and in particular, I want to give a huge round of applause to our panelists because they did an outstanding job. Really outstanding. It can be tricky to be in these spaces, but I think they were outstanding, and I think that the future of medicine and healthcare is in very good hands. That's all I have to say. The other thing, I did tell you that we have a save the date out, April 30th. The office is going to be presenting Lee Walters, Best Practices for Intergenerational Communication, a Train the Trainer half-day program. That should be put out pretty soon here. So those of you who are engaged in this work and want to do a better job, share it too with your training directors and other individuals so we learn how to really actually put into action what we've been talking about tonight so that we can create a safer environment for our trainees and learn from each other. So with that, I invite everybody to the reception and to continue the conversation, and thank you so very much for the privilege of your attention.